Okay, Amanda, are you ready to get started? And I just started recording, just so everybody knows.
Yep, I am good to go. If everybody can just make sure that their microphones are muted, so we don't have any interference. We'll go ahead and get started. So I just want to welcome everybody. Good afternoon. Thank you for taking time out of your busy days to spend with me and learn a little bit more about ADHD. My hope is that we all take away at least one new thing from this, and are better able to help our clients live their best lives. Karina, I'm ready for the next slide. All right. So what is ADHD? It is a cluster of symptoms that show a pattern of inattention, hyperactivity, and impulsivity that interferes with a client's development and or their daily functioning. This means that our clients see impairment in two or more areas of their life, which could be personally, professionally, or academically. Currently, there are three types of ADHD. There is the inattentive type, hyperactive, and then combined presentation, meaning we see characteristics of both inattention and hyperactivity. The client needs to exhibit 6 or more symptoms, which we'll go over, 5 or more symptoms if they are over the age of 17. We have to see these symptoms for at least 6 months, and these symptoms have to occur more often than not. It's not mom coming in with little Johnny and says, well, sometimes he doesn't listen to me. Sometimes he doesn't follow through with things that I ask him to do. It needs to be a pretty regular pattern that is disruptive in their life. Also, making note, inattention does not equate to oppositional behavior, doesn't equate to defiance or hostility. And one question that I make sure to ask my clients, especially in the younger population, is when I'm talking about academic performance, asking a client if they understand what they're being taught. If they don't understand the content, then I kind of look more towards a learning disability or some other diagnoses. Whereas if they do understand the content, they're just not able to sustain focus, then I kind of continue down that path of, is this potentially ADHD? Now, inattention, hyperactivity, and impulsivity are all thought to arise from inefficient information processing in various parts of the brain that involve the prefrontal cortex. Executive function seems to become a buzzword of sorts in the social media world. And actually, that word more accurately describes the inattentive component of ADHD. It deals with one's ability to actually focus on something and be able to sustain that focus. And that is thought to be controlled in the dorsolateral portion of the prefrontal cortex. Hyperactivity is controlled by the prefrontal motor cortex, and the impulsivity is in the orbital frontal cortex. In clients with ADHD, they don't activate these areas appropriately to respond to the cognitive tasks of attention and problem solving. All right, next slide. All right, so diving into inattentive symptoms of ADHD. Again, these symptoms have to occur more often than not in order to be considered a symptom. So first we have fails to give attention to detail or makes careless mistakes. Again, the question I like to ask, especially in school-aged clients, is when they do a test review, do they find that they missed multiple questions in a row? And this can indicate that the client wasn't able to move forward and focus on the new content when reading the questions. It seems that they are more so hung up on the question that they weren't sure about, and then probably misread a following question or one of the answers and then got that one wrong as well. It can also be that clients don't read all of the instructions before beginning a task and then leading to a mistake. They have difficulty sustaining attention. These are the clients that zone out during lectures or during class. School-age kids, those are the daydreamers, the ones that are doodling in class. It can be the client that tells you they have to read something multiple times in order to understand what they've read. You may hear, I can read something, and when I'm done, I literally have no idea what I've just read. Okay, is there a question already, Michael?
So just kind of a quick question. You might have posted this already. I'm not really sure, but you're talking about ADHD and then you mentioned briefly about assessment for a learning disability. Now, did you focus on or maybe you will, around how ADHD is encompassing for a learning disability?
No, unfortunately, this topic is just more so assessing for ADHD. I don't really dive into anything more with the learning disability portion of it.
Okay. Okay, so you're just, it sounds like we're just going through a very broad stroke, correct?
Yes.
Thank you.
Okay. Um, all right. Number 3, they do not seem to listen to when spoken to directly. Again, might be the daydreamers who don't realize the teacher has called on them or an adult in a meeting who has been asked for their input, and then they realize that they have no idea what's been talked about thus far. Parents of children may tell you that they have to repeat themselves all the time because their child simply is not listening to them. Next slide. Number 4, they do not seem to follow through on tasks or instructions. They fail to complete schoolwork, chores, or work responsibilities. This can look like the adult client that comes in and tells you that when they clean their house, they start one project. They may start with the dishes. They find that they need to put something away in their office, go into the office and see that there's paperwork and mail that they have to go through, going through the mail, and then go back out to the trash and realize that they haven't even finished the dishes. So they kind of start one project after the other, and don't really finish up anything in any timely fashion. It can also be the client that will tell you, I pick up hobbies all the time. They become fully engrossed, hyperfixate on these hobbies. But the first sign of difficulty, or if they become bored with it, they simply drop it and never even consider it again. In our school age clients, it can mean that they start a homework assignment during class, but when they get home that they completely forget that they have that assignment that is due the next day and just don't finish it. Number 5, they are disorganized. These are the clients that are habitually late to events. These are the people that you'll hear their families say, you're going to be late to your own funeral. Again, they miss deadlines in school and work. They have trouble keeping things organized and may even appear as messy. Next slide. Number 6, they avoid, dislike, or are reluctant to engage in tasks or activities that require sustained mental focus. These are the clients that may need subtitles in order to watch a movie. They might tell you that they have trouble filling out or completing forms, or that they simply can't or never have read an entire book in their entire life. Number 7, they lose things necessary for daily life. These are the clients that will lose their wallet, cell phone, keys, or they've developed a workaround in life, meaning that everything has a home, and if it's not in that home, then it's lost forever. My son-in-law happens to be the prime example of this. This man has an AirTag on his wallet, on his keys. I think he told me the other day he actually, my daughter put an AirTag on his Yeti because he's been losing that as well. And he regularly has to pull it up on his phone to find out where he's put those things. In kids, it can look like them forgetting books, forgetting their laptops, either at school or home, forgetting to charge the laptop, and it's dead the next day and they can't use it at school. Number 8, they are easily distracted. Karina, this is if you want to start bringing up the clip. The example I like to use is from the Pixar movie Up. There's a dog named Doug. For anybody that's familiar with this, we're hopefully going to have a clip here momentarily.
Yeah, 1 second.
So while she's bringing that up, this easily distracted, it can look like they have unrelated thoughts in their head. They may tell you that their brain is never quiet. There's always a conversation or monologue going on in their brain. They may be frequently off topic or may seem circumferential in their thought process. These are the people that tell stories within stories, give extraneous details before actually getting to the whole point. All right, I think we might have a clip. Hopefully we get volume today. Nope, apparently not. So this is Doug. He's like, hi, my name is Doug. He's telling him, my master made me this collar. And then all of a sudden, he looks away, squirrel. So again, these are the people that are distracted, having a conversation. All of a sudden, their focus is completely off topic. I honestly don't know which number we're on, but no, you're fine. You're fine. The next one is that they're forgetful. These are the clients that have trouble remembering to pay their bills, even though they have the money to do so, or because they know that they're forgetful, they have everything set up on auto pay, so they don't forget to pay bills. And maybe the client that has to go to several stores to get all of the ingredients that they need for a certain recipe because they've gone home and realized that they don't have what they need. Could be the person that frequently no-shows you or is late for their appointment because they forgot. For school-aged kids, it might be the kid that tells their parent the night before they have a big project due. And that leaves mom and dad scrambling to help them put everything all together, going to Walmart at 9 p.m. to try and get everything they need to make the solar system project. Next slide. Okay, moving on to hyperactivity and impulsivity. Just to kind of review again, we need to see at least 6 or more symptoms that occur for at least 6 months. Again, it's 5 or more in people over the age of 17. Again, they have to happen more often than not and be problematic in their lives. We need to be able to rule out other causes like depression, anxiety, mood disorder, or even some form of addiction. Next slide. Okay, so I'll be honest with you all, the hyperactive symptoms, I tend to struggle a little bit more with differentiating between, and it is likely because I am the poster child for inattentive type ADHD. But number one for hyperactivity is they often fidget tap their hands, squirm their feet. It's pretty self-explanatory. Number 2, they often leave their seats when it's expected to remain seated. These are the school-age kids that might get in trouble for getting out of their seat in class. For adults, it's the person who is never where they're supposed to be when you're trying to find them. They're always out wandering around talking to somebody else. Number 3, they often run or climb in situations that's not appropriate. These are the kids that are in our waiting rooms and in our office. They're climbing on furniture, crawling on the floors, running down the halls. In adults, it can just present as a sense of restlessness. Next slide. They are often unable to play or engage in quiet activities. Again, this comes back to the client that can't just sit and watch a movie. They may get bored, lose interest, feel like they just can't sit there any longer and have to get up and do something. Number 5, they are often on the go or they act as if they're driven by a motor. Again, this looks like restlessness. You might hear a parent tell you that their child never stops moving, always on the go, always doing something. For adults, it can be the client that paces. They may reposition themselves frequently during your appointment with them. Number 6, they often talk excessively. I generally ask clients, adults, especially if they got in trouble in school for talking, or if they were the kid that got the little comment on the report card that says, pleasure to have in class, just talks too much. This could also be the kid that's always cracking jokes, kind of the class clown. Next slide. All right, these are more of the impulsive symptoms of ADHD. They often blurt out information. These are the clients that try to answer your question before you've completely finished asking it. May also be people that complete other people's sentences because they think that they know what you're going to say and they just simply can't wait for you to finish that sentence. Number 8, they have difficulty waiting their turn. They have their turn, they have a hard time waiting their turn in conversations, may cut people off when they're talking. For adults, it could also be the person that has trouble waiting to check out at the grocery store and may just leave their cart there because they simply just cannot wait. They're just bored and restless. Number 9, they often interrupt or intrude on others. The examples I like to use when assessing this is I ask them if they frequently interject in conversations that they're not initially part of, or if they give out their input when it really wasn't asked for. Another example I like to ask is if they try to quote unquote help somebody with something but end up taking over that project altogether. It can also be the kids that get in trouble for taking things without asking for permission first. Next slide. Okay. So now that we've kind of gone over the inclusion criteria for ADHD, let's look at some of the exclusion criteria. So regardless of what age you are assessing your clients, we had to have seen these symptoms, or they had to have seen these symptoms prior to the age of 12. So it's not the adult that's coming in and at age 40 and has a change of job and is all of a sudden like, I can't focus. It might be, but if they hadn't had issues prior to the change in job, it's likely not ADHD. Symptoms have to occur in at least 2 settings. Again, this could be at work, at school, their personal life. I think we've all had the client that has come in certain that they have ADHD. But again, these symptoms have popped up after a life-changing event, like the birth of a child, change in job. I know personally, I saw a ton of this during COVID when people all of a sudden, one day were going into the office, the next day they were expected to work from home. Not everybody has a dedicated space, a workspace at home. So we, as people, were being expected to kind of intermingle our workspace with our home space. And it was hard for a lot of people's brains to kind of say, okay, I'm at home, but I need to focus on work. In those situations, I try to help people come up with ideas or ways to manage that. It can be you have a certain seat at the dining room table that you use. You have specific hours that you plan to work. If you need a break, you set an alarm so you don't get distracted on doing other things like flipping the laundry, making the kids lunch. So you're able to get back to work at a reasonable time. Lastly, there needs to be clear evidence that these symptoms are negatively impacting their life. We often associate this with poor academic or work performance, but it also could reflect in their personal relationships. Could be the person that forgets their friends or their loved ones' birthdays or important dates. They may just simply show up to events that they forgot that they committed to going to. Next slide. So what other diagnoses can present like ADHD? We kind of touched on this, but in adults, we should always be assessing for mood disorders like bipolar, specifically mania, which can mimic the hyperactive or impulsive symptoms of ADHD. Depression and anxiety can mimic the inattentiveness and forgetfulness. And then lastly, substance abuse can be misdiagnosed as ADHD with symptoms mimicking inattention, hyperactivity, and impulsivity. In children, again, depression and anxiety should be ruled out. And if present, if we find that they do actually have anxiety and or depression, we should be treating those first before we assess for ADHD or treat ADHD. Learning disabilities and defiance can also be mistaken for ADHD. We should also be looking at a child's home environment too. Are they getting the attention and stimulation that they need, or are they trying to just simply act out in order to get that attention? I make sure to ask parents and guardians what kind of reports they're getting from their child's daycare or school. Because if a parent tells me that they aren't having any issues in school, only at home, I try to look into this a little further to try to see what's really going on here. It doesn't mean that if someone has one of these other diagnoses, whether it be depression, anxiety, bipolar, whatever, that ADHD is automatically ruled out. I'm sure we all have clients with multiple diagnoses, We just simply have to be confident that the symptoms that they're reporting to us that are problematic can't be better explained by another diagnosis. Next. All right, so how do we treat ADHD? When I have a client that I've either diagnosed with ADHD or they've gotten a diagnosis elsewhere, depending on where they've gotten this diagnosis, I have a conversation about medications. I start by explaining there are two types of medications. There are stimulants and non-stimulants. And listed right now, you can see some of the more common stimulants that we tend to use. I try to explain to clients that stimulants are controlled substances. They carry an increased risk for abuse, misuse, and diversion. These medications are tracked more closely than non-stimulants, like your PDMP, and that the prescriber, as a prescriber, we have certain limits on how much we can prescribe. As a nurse practitioner here in Pennsylvania, I can only prescribe 30-day supplies at a time, and those prescriptions expire after 6 months, whereas a non-stimulant prescription here is good for a year. I also explained to them that stimulants can offer a little bit more flexibility, that they don't necessarily have to be taken on a daily basis. They don't have to build up a serum level in your bloodstream in order to be effective like a non-stimulant. This might be attractive to parents who are hesitant to medicate their kids because it offers them the flexibility of doing medication vacations over weekends, long breaks, holidays, that sort of thing. It helps the kids who are not great eaters and they struggle to keep up with their nutrition while on stimulants. However, this doesn't mean that their child will not experience a return of symptoms if they don't take the medication, because they absolutely will. So I often tell parents that they need to kind of look at what's best for their child and for their family. And if Johnny is causing the household to be in chaos when he's not on his medication, then he might not be a good candidate for vacations, and he might need to be on his stimulant all the time, or look at a non-stimulant. Now, all of the stimulant medications are derived from either an amphetamine salt base or a methylphenidate base. Both amphetamine salts and methylphenidate work to increase both norepinephrine and dopamine and block their reuptake. Norepinephrine plays a role in executive functioning along with dopamine. And the theory is that individuals with ADHD is that the norepinephrine neurons in the prefrontal cortex fire at a lower than what's considered normal rate, and that contributes to the cognitive dysfunction. So increasing these levels should help improve their symptoms. However, there can be such a thing as too much of a good thing. When norepinephrine levels are too high, like with times of stress, with other comorbid conditions like anxiety, mania, substance abuse, the overabundance of norepinephrine can contribute to a reduced working memory. This theory also applies to dopamine levels. So overstimulating the dopamine receptors is thought to contribute to worsening cognitive function. Next slide. All right, here you see most of all the non-stimulants available to treat ADHD. The one that's missing is Qelbree, which is newer out on the market. It's in the same drug class as venlafaxine or Effexor, so it's an SNRI. Strattera is similar to Qelbree and Effexor, but it doesn't target serotonin, it only targets norepinephrine. Guanfacine and clonidine are approved to treat hypertension in addition to ADHD. For ADHD, they target the postsynaptic alpha-2A receptors, which happen to target norepinephrine levels in the prefrontal cortex. When they target the blood pressure, it's the receptors in the brainstem. Wellbutrin can also work to increase norepinephrine and dopamine levels, and it also blocks the reuptake of those neurotransmitters. Common side effects of non-stimulants can include sedation, most notably from like guanfacine, clonidine, sometimes Strattera, nausea, GI upset, again, common with Strattera. I've had some reports from clients on Qelbree. Those tend to be transient and will go away if you can get your clients to kind of stick it out. It should get better. Since guanfacine and clonidine can lower blood pressure, dizziness can be a side effect of these medications. Regardless of what medication we end up prescribing, I always educate clients, parents, that it is super important to make sure that they're staying well hydrated, because a lot of the times side effects can include things like dry mouth. Next slide. All right, so this is just kind of like dosing guidelines for stimulants. I'm not going to insult your intelligence by trying to read this to you. Next slide. Okay, things to take into consideration. What length of time does your client need coverage for? Do you have any concerns for abuse or misuse? Or have you assessed for family or personal history of substance use disorder and alcohol use disorder? Short-acting stimulants can be helpful for those who have a long work or school day and feel that extended release kind of wearing off before the end of their day. With regard to short-acting stimulants, amphetamines tend to last a little bit longer than the methylphenidates, with amphetamines lasting anywhere from 4 to 6 hours. Again, this is immediate release formulation, whereas methylphenidates tend to get you 3 to 4 hours. These medications are more prone to cause a crash or rebound irritability. I tend to tell my clients I don't like using short-acting stimulants as a primary, unless they have like an altered GI tract with like reduced capacity for absorption, because they tend to have more mood lability. There's highs and lows because the drug levels spike and then drop, but spike and then drop. Next slide. Studies have shown that the long-acting stimulants are less likely to be abused, and there's new technology out there that has made prodrugs. Prodrugs have inactive versions of the methylphenidate and amphetamine, whichever base you're using, that do become active amphetamine and methylphenidate upon metabolism in the body. So it makes it harder to be abused or misused. Examples of those types of medication, prodrug medications, would be Vyvanse, which is an amphetamine base, and Astaris, which is a methylphenidate base. If you are considering adding an immediate release product to a client's regimen, the general rule of thumb is to stick with the same base, meaning amphetamine or methylphenidate. I typically tend to use a lower dose of an immediate release product to reduce side effects like insomnia, anxiety, decrease in appetite. So if I have a client that is taking like Adderall extended release 20 milligrams in the morning, that 20 milligrams through the extended release is being microdosed throughout the course of the day. Whereas if we give them immediate release 20 milligrams, they're getting all of that right up front. So they can have a higher incidence of side effects. It's important to educate clients that food can affect the bioavailability of the medication. And one thing that I've learned in recent years is that vitamin C can actually reduce the absorption of a stimulant. So I tend to tell my clients to avoid any vitamin C within an hour or two before and after they take their stimulant medication, just to reduce the risk that it's not being absorbed. Next slide. All right, common side effects of stimulants can include any of these. One thing that I find interesting is the number of clients that report back to me that they're actually sleeping better on their stimulant. And I think this kind of goes back to the distractibility and those random unrelated thoughts. Oftentimes, these are the clients that tell me that it's been easier to go to sleep because their brain's been quiet. Decreased appetite, it may or may not improve over time. One stimulant that you want to use cautiously in somebody with a poor appetite is Vyvanse, because it is also approved to treat binge eating disorder in addition to ADHD. Increases in heart rate and blood pressure tend to be on the lower side, 2 to 6 beats per minute for the heart rate, and less than 5 points value for blood pressure, according to a meta-analysis I found on NIH. However, this meta-analysis also did recognize that they don't have a ton of research on adults, so more research needs to be done on that and potential cardiovascular impact. And obviously there is a risk for mood changes, again, that rebound irritability, increases in anxiety, and as we've already said, the risk for abuse. Next slide. So what should we be testing for, screening for in our clients that we're considering treating with a stimulant? Is there any family or personal history of cardiovascular issues? Again, any substance use disorder, alcohol use disorder. Make sure you're getting a height, weight, especially in kids, trending that over the course of treatment. Should be getting a baseline blood pressure and heart rate. Because again, we can see increases with stimulants and decreases in blood pressure in particular if we're using non-stimulants like guanfacine or clonidine. As far as testing goes, urine toxicology screening to make sure that they are not actually abusing any substances they're not supposed to be. And you might want to consider an EKG if there's a family history of cardiac issues or if your client is over the age of 50. Next slide. Make sure you're checking off your PDMP every single time. It's funny how many times I'll have somebody come in and I've been seeing them for months or years, and all of a sudden their PCP is prescribing them something new, and we have to have a conversation about it. I've had people come in and all of a sudden they're like, oh yeah, my doctor's treating me for my obesity and they're on phentermine. I have to tell them, okay, well, that's also a stimulant. Now we need to choose which one we're going to use. So again, excuse me, we need to be looking at how many other controlled substances are being prescribed, how often they're filling those prescriptions. We should be starting stimulants on the lower end and then increasing based off of their reported symptoms. If a client starts by telling me throughout their entire appointment that everything's fine, good, no issues, and then at the end of the appointment, they're like, well, you know, I wanted to see if we could increase my stimulant. Then we kind of need to go back and reevaluate, like, what are we seeing here? Are we just trying to see if things can be better? So in those cases, what I kind of delve into is when the medication is in your system, do you feel like you are getting adequate coverage? Like you feel like you are able to sustain attention, your task initiation is okay, things like that. And if they tell me yes, but they're not getting the duration that they need, then that's when I consider adding a shorter acting stimulant to the end of their day. If they're telling me, no, I'm still really distracted, having a hard time starting projects, you know, regardless of what time after they've taken the medication, then yes, increasing in a longer acting product would be appropriate at that point. Again, making sure you're documenting height and weight, especially in our pediatric population, to make sure that they're maintaining good nutrition. And again, we need to make sure that we're educating our clients that as prescribers, we have limitations on what we can prescribe. Next slide. All right, so what do we do? Our clients come to us and tell us that they're having side effects. The client comes in and tells you that their heart rate's increased or they're having anxiety, you might want to consider trialing them on another stimulant or considering a non-stimulant medication at that point. For insomnia, make sure your clients are taking it if they have at least 5 or more hours in which they want to be awake. You don't want them taking something at 7 o'clock if they're trying to go to bed at 9. If they are doing everything appropriately and they're still having issues with sleep, you may want to try to decrease the dosing, switch the formulation from potentially an extended release to an immediate release, or switching the base medication. Next slide. Appetite suppression. You want to encourage your clients to take their medication with a meal. Educate them that if they already have a poor appetite, they might want to keep small on-the-go snacks with them to eat when they do feel hungry. And they might find that they're not able to eat as large of meals as they were prior to taking a medication. And again, monitoring height and weight in our pediatric population. Irritability and other mood changes, again, switching the base formula, reducing the dosing may help improve these symptoms. Next slide. So what do we do if there is a partial or no response to medication? Again, moving to a different stimulant, trialing a non-stimulant, augmenting a stimulant with a non-stimulant like guanfacine or clonidine, and then always augmenting with behavioral interventions. On slide 24, I believe, I have a list of books that are good recommendations for your clients if they want to read up more on like non-pharmacological ways to improve their ADHD symptoms. Next slide. So these are just some additional guidelines. That third one, the drugs for adult ADHD, is actually a pretty nice table into onset, duration. I do believe it has like max peak, those kinds of things. So that's often helpful if you're trying to fine-tune dosing with different stimulants. And then next slide, I believe, is the list of books. Yeah. And that's it. Questions, comments, concerns, issues, problems. Nobody? Okay. I believe this will be available. Yes, May?
Yes, so I have a question. I mean, I guess this is a question that most people may also have, since we get a lot of, patients coming in with who wants to be, evaluated for ADHD. There's this list that we have for like neuropsych testing and places that we can maybe possibly send patients to. But I'm in Maryland and we don't really have much from the ones that we have on that list. There's Kennedy Krieger, which takes like 6 months to a year. There's a huge waiting list, and the maximum age is 30. The other ones on the list that I called, they're like, no, we don't do ADHD testing. And I've been trying to look around. Most people either charge, they don't take insurance. And because it takes so much time figuring out if they really have ADHD or not, some people even get offended when you say they don't have it. I'm just wondering, like, what is the best way that will be efficient for us in this practice that will work for us? Because it's crazy. I mean, even from today, tomorrow, I have so much more ADHD patients coming in. And at this point, I'm like really just exhausted. I don't know what we can do.
Yeah, no, I definitely empathize. I mean, I always tell people use your clinical judgment. I mean, right? It's your license. And if you are not comfortable evaluating and assessing for ADHD, then it still is appropriate to refer out for neuropsych testing. I know that there are some online programs. They're subscription based. So I don't know how available or affordable that is. It's called, the one I know of is called Creos testing. So it's CREYOS. They offer all kinds of neuropsych evaluations that clients can do on their own time. Actually, just look here real quick to see if they have like a list of providers that do offer their testing. They don't. But yeah, to kind of answer your point, I know that a lot of people do get offended when you're like, yeah, I don't think you have ADHD, my friend. And it can be frustrating and disheartening. And sadly, I don't really have a great answer for you other than, looking into those neuropsych evaluation places. I can tell you when I initially started practicing, I was not comfortable assessing for ADHD, and I referred almost everybody out for neuropsych testing. As I've kind of become a little bit more confident in my practice, I do assess a little bit more. But if I have any doubt, then I'm referring those people out for a neuropsych test. I don't know if that answered your question or helped at all.
I mean, Kind of. I mean, just curious, like how many appointments do you take to say, okay, maybe efficiently diagnose somebody with ADHD?
So especially in adults who have like underlying anxiety disorders, it can take a couple of months in order for me to be like, yeah, you know what, let's reassess you for ADHD. I think that your anxiety seems to be under pretty decent control. But there are always clients that come in. There's a handful that always come in and you're like, oh yeah, it's clear. Yes, my friend, you definitely have ADHD. Any other questions? I think I saw a question about. Okay, that was already answered about the slides and handouts. Okay. All right. If nobody else has any other questions, I will let you all move on with your lives. And I thank you again for coming and joining us. And I hope it was beneficial for you all. Have a good day.